EuroPD News.
Helsinki, July 2007. Thank you for joining us on EuroPD News. It's been a very successful meeting here in Helsinki with more than 1,500 delegates, and over 500 representatives of the industry were here to focus on scientific research to provide the best possible peritoneal dialysis solutions. Now here's a summary of the scientific highlights of the meeting.
So it appears that the N-terminal proBNP is actually a very useful marker in predicting outcome of the chronic PD patients, and most important of all, it seems to have additional prognostic value beyond that of the standard echocardiographic measures. So it seems that the elevated cardiac troponin T is not just reflecting the myocardial necrosis, but in addition, it is able to identify a subgroup of patients who are the sickest patients and who are at an increased risk of mortality and cardiovascular death.
And the age at which we transfer a patient to the adult unit depends upon many factors. Depends at which stage they have finished their growing and they are right to go into adult care. We therefore have this issue about going from an area where there are smaller numbers of patients, individualized care, good support, to the adult unit where that support is lacking.
Maybe there is not a link between intraperitoneal and systemic inflammation. So my hypothesis here is, in fact, that intraperitoneal and systemic inflammation are not coupled, or at least not necessarily coupled. Again, some more studies which I was involved with from Tom Stompor, again showing that systemic IL-6 was really associated mostly with loss of residual renal function and not particularly associated with membrane transport status.
Joining me now is Professor Nick Topley of the Scientific Committee at EuroPD. Nick, what's the scientific value of the meeting? For example, the session with Angela Wang?
Well, I think there have been many highlights, but Angela's data is very intriguing because it identifies new factors that we could measure in patients which would predict outcome, and particular cardiovascular outcomes. This is very important because it's the major killer in these patients, and if we can identify them early, we'll be able to treat them better, and then they will survive longer on peritoneal dialysis.
Now, another session with Alan Watson was on treating young patients.
Well, as usual, Alan was very provocative, but I think he presented some very key messages. He took the pediatric perspective and applied it to the transition to adult nephrology. And I think it's one of the areas they are much better than we are in terms of supporting patients. And I think there were many things to learn, and later sessions took this on board in terms of the development of multidisciplinary teams to support PD patients.
And another symposium, From Inflammation to Fibrosis, Simon Davis.
Simon has done a lot of good work, and he presented some new data looking at intraperitoneal markers of inflammation, because for a long time we've assumed that there was a link between systemic and intraperitoneal inflammation. I think we're beginning to understand now that local inflammation within the peritoneal cavity may be more important in predicting membrane failure, and that systemic inflammation may be more important in predicting the loss of residual renal function. Obviously, both of these are important in terms of PD longevity.
Okay, we'll talk later in this bulletin. Now let's switch to our colleague Jeroen, who has been investigating how the EuroPD delegates think about training in PD.
This topic came across earlier this week as well, as we talked about what we can learn from the pediatric nephrologists.
I think that many units lack the necessary support that patients need to actually do well on peritoneal dialysis. Many units don't have a social worker. Many units don't have the availability of psychologists. Many of them are deficient in the number of dietitians that they have. So there's a whole lot of support mechanisms which I think aren't adequate in adult units.
And talking about the training, during this week we talked a lot with delegates about the training for the doctors themselves. That should get a lot more attention. Patients in the US undergoing PD treatments are doing much better than the ones on hemodialysis. But strangely enough, the number of PD treatments in the US and in other places are in steep decline.
The decrease in PD take-on cannot be attributed to the change in the demographics or the medical conditions of the patient. So there are conditions outside of their medical conditions that account for the decrease.
In general, they don't get enough training.
I think it is a combination of the lack of familiarity amongst physicians about PD.
Well, the consequence is obvious. I mean, when you have, as a nephrologist, when you have not had enough training in PD, you're unlikely to prescribe it to your patients.
I think more emphasis can be put on PD than it is at the moment, yes.
Because the training is largely related to hemodialysis, and the lack of information given to the patients about the option of doing home dialysis. And I think those are two areas to work on to improve the PD take-on.
So I think one of the main things that you should do to try to change that is start giving courses on peritoneal dialysis. Theoretical courses that can be extended with practical training also.
At the moment, a lot of these courses are being paid by the industry. Is the medical sector relying too much on the industry?
I wouldn't directly say too much because, well, we need industry needs us. But of course, I mean, when you see it from an overall perspective, it would be better when those courses would just be incorporated in the normal training for nephrologists.
I think it can be very useful for renal trainees to have a structured teaching program, like 3 to 4 days, really, by eminent specialists to get involved theoretically, and then a hands-on experience for 4 to 6 months, and to be responsible for a PD program in your center.
Now, some like to call them the sponsors or the industry, but we've been able to notice that the partners of EuroPD are as concerned about the patients as we all are.
Keeping phosphate levels low is one of the challenges for physicians treating renal failure patients.
The main problem is it causes problems with the bones and the other minerals in the blood, so that patients can get very ill.
At EuroPD, the industry presents solutions for hyperphosphatemia. Since a couple of years, there are new medicines on the market without the harming calcium or aluminium.
Well, sevelamer actually attenuate calcification, and what we can see now, that helps also in terms of survival. And it does not, it's not absorbed, and it does not accumulate in the patient's bodies. There's also a great benefit with sevelamer.
The only problem with the current available medication is that it requires patients to take a lot of pills.
If you look at what happened in the past with available treatments, the pill burden was definitely a big problem, and we have the solution for that now. That with Fosrenol, you only have to take minimum 1 pill per meal per day.
It's difficult to ignore the presence of the industry here at EuroPD. You must have seen Fresenius Medical Care here at the Central Hall, where you have your coffee break in Finlandia Hall. And standing next to me is Mr. Marcus Roberts of Fresenius Medical Care. Mr. Roberts, I'm wondering what message you want to give to the delegates.
Yes, the big message is that as a market leader of dialysis care, we're here to show the continuum of care and the full commitment to the peritoneal dialysis that we have here. And we want to really emphasize that we are doing a lot on improving survival.
Another big company present here at EuroPD is Baxter. It was one of the first companies to be involved in PD. Earlier today I spoke with David Watson of Baxter about the improvements of the PD treatments.
For example, again in systems with APD systems, we think that there is clearly room for a next generation APD system. In solutions, Physineal and extraneal and neutroneal, we think are great solutions. But again, as we talk now, we're looking for what are the next solutions? What are the things that we can bring afterwards, which will take the care of patients onto another level?
Well, that was earlier today. Baxter is currently working on some improvements of the APD systems. The company thinks it can give some more information about this in the next coming months. Gambro presented some new interesting scientific data on how to preserve the patient's kidney function even when they have started dialysis. The company stressed the importance of sharing information between the industry and the scientific world.
In the situation we are now when it comes to PD therapy of underutilization, a sort of a suspicion from the established dialyzing people, I think we all need to get together and promote all the good things that there are in PD therapy. And we're doing that together, and I think that I don't think anybody would deny that. We need each other.
I was told that an HD defender would join us here at the meeting in Helsinki, and surprisingly, he was the one to confront the delegates with some interesting insights.
Some would call Roger Greenwood an HD guru, yet he wanted to attend EuroPD. His view is that the whole system needs a change. HD is often the easiest choice.
It's financially driven laziness also. 100 million people The whole pathway we need to redevelop, if you like, which we've never done before, because hemodialysis is easy to initiate. It's a kind of laziness and inertia in the system. It's got to be said. And to run PD and conservative management programs, you've got to have an active education input. And sadly, with the pressures and financial pressures, it's not just the cost of a therapy, it's the teams you've got available.
But you need a budget for all that. This makes HD a popular choice, which doesn't always benefit the patients.
When we think about patients looking towards many decades of survival, we've got to be quite intelligent about how we initiate therapy. We've got to think about vascular access. Should we really start vascular access early? It's not a good thing to do too early in some cases. So I think PD, could actually increase in popularity if we think in terms of the long-term plan.
Now, to make these plans reality, the system needs a serious wind of change.
What you need is a multidisciplinary team to educate patients, and that's what we've developed. And it's a whole multidisciplinary team of social work, counselling, nursing, medics, and who actually see patients early on in their own homes, give them the full array of options available, and that's where we need to concentrate effort. So it's not doctors, it's a laziness in the system, it's an inertia in the system. And of course, that's all about holistic care of chronic disease, and that costs money. And health authorities are increasingly looking for the short option, quick money here for a quick treatment here, and that's very bad for chronic disease management.